Now, overall, this is where things become important. The important points of what you want to know about ECG are the following. What is the rate that you're looking for? How do you find the rate? You're going to take a look at the space or the span between the R waves. Think about the R wave. First, major positive deflection. And what's my phone number? 300, 150, 100. 75, 60, 50. Keep saying it over and over and over and over again. Practice in the mirror. Practice with me so that you get those firmly etched in your head. For every line that is separating the R wave, you're going from 300 beats per minute all the way down to 6 lines separating the R wave, resulting in Brady and 50 beats per minute. That's your rate. Is it regular or irregular? Meaning to say, let me give you a prime example. In atrial fibrillation, was it irregular or regular type of rhythm that you saw in that lead? Atrial fibrillation, you had a P wave, which was fibrillating and wavy, and it was irregular. The QRS complex showed up randomly. Whereas in atrial flutter, I showed you a 2-to-1 type of ratio. That type of pattern was 2 P waves to every QRS complex. And that was a regular rhythm. You see that now, crystal clear. Now, what about the QRS complex? Is it narrowed or is it perhaps widened? So far, what we've seen is a widening of our QRS complex. Prime example, WPW, Wolf Parkinson White. What caused that widening of a QRS complex? QRS complex, the delta wave. What happened to PR interval and WPW? It got shortened. Are you able to do it that quickly? Yes, you are. You'll get it. Clinical picture. What about your patient hemodynamically? Is your patient hemodynamically stable? If they are, maybe, just maybe, you have enough time and you have the luxury of using medical cardioversion. In other words, drugs. Or if your patient is hemodynamically unstable, what does that mean to you? There's syncope, there's dizziness, decreased cardiac output, there's dyspnea. Oh, wow. Things are backing up into lungs. Hemodynamically unstable, hypotension. And now you're thinking about what kind of issue or what kind of cardioversion? Electrical. Blood pressure, consciousness, distress. All right? That to you should indicate in the setting of an arrhythmia as to whether or not your patient is hemodynamically stable or unstable. Know this forevermore. Not only are you going to save the lives of your patients, but really you're going to build confidence in yourself to make sure you can approach any scenario and you can walk away knowing that you have done a good job. Now, what else do we want to know? Clinically unstable, shock is what you're worried about. The heart is failing. Wow, cardiogenic shock. How is the patient going to feel with this type of shock where the heart's not pumping properly? You tell me. Decreased cardiac output, so therefore what happens to blood pressure? Bam, decreased, right? Decreased. Tell me about your baroreceptor reflex. Decreased firing, increased sympathetic activity. With that increased sympathetic activity, how is the skin going to feel? Cold and clammy, and there's going to be diaphoresis. Are we clear? Why? Because increased sympathetic activity. Shock. Hemodynamically unstable. Narrow complex, regular tachy, and clinically stable. What about this patient? Vagal maneuvers. Let me give you a big one physiologically. Right here. Carotid massage. A carotid massage has a particular component in it. In the carotid, huh? And this component is called a sinus. And this sinus houses what exactly? The carotid sinus houses baroreceptors. Chemoreceptors are in your bodies, aren't they? So here, let's focus on the carotid sinus that contains baroreceptors. And your patient has a regular, tachy, narrow complex of your QRS complex. Clinically stable, there is no major hypotension. Distress, not so much. And the syncope and dizziness, not there. We're okay. Shock, no. Obviously not. Stable. You want to slow down the heart rate. Are you seeing it now? You massage your carotids. Let me give you worst case scenario. What if you were doing a thyroid exam on your patient that has a goiter, and you come from the back and you press upon the carotids both at the same time? You might have just killed your patient. The heart, you have cardiac arrest. Why? You massage a carotid, you have stimulated the baroreceptors. When do you have your baroreceptors being stimulated? Increased or decreased blood pressure? You tell me. Take your time. You got this. Increased blood pressure, increased amounts of blood passing through the carotid. That's more sensitive, isn't it? So when you have increased blood pressure and you stretch, you with me? You're stretching your blood vessel. You're stimulating the baroreceptor. Out comes the parasympathetic. You, by performing carotid massage, are mimicking high blood pressure, increased blood flow. Okay? So, hemodynamically stable, be careful, when you do a carotid massage, you would expect the heart rate to decrease. Valsalva, what's that mean? Well, same thing, in which we talked about that earlier with Valsalva when we did phase 2 and such, and we were doing our maneuvers where it decreased preload. Valsalva could also result in maneuvering and vagal response. Adenosine, IV, unless which one, please? WPW. What else are you going to avoid in WPW? One more time. You tell me about DIG. DIG is the big one. Technically, calcium channel blockers as well. All right? May terminate your re-entry tachycardia. You pay attention to RT right now. That's good enough. All right? Re-entry tachycardia. Will make flutter waves more clear. Adenosine, because you're slowing down conduction. May not terminate atrotachy, but will slow AV conduction so that abnormal P wave focus is what you're paying attention to. Is that clear? So you're really slowing down the AV conduction, but may not necessarily terminate the atrotachy. Will transiently slow atrial fibrillation. And as you move on to clinical medicine, and those of you that are already cardiologists, those of you that have done your cardiology rotation, you know exactly what I'm referring to. Many times you use adenosine to do what? Diagnose your patient, right? You use adenosine to see as to whether or not by giving it, have you slow down the heart rate just a little bit. And if you've done so, well, maybe you've diagnosed your patient with an SVT of some type. Keep that in mind. Transiently will slow down atrial fibrillation.